Hello and welcome to the MIMS Learning Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell and I am a medical editor at MIMS Learning. Today I will be speaking to Dr. Prina Ruparelia about chronic cough in adults. Prina is the Joint Clinical Director for Respiratory Medicine at St Bartholomew's and Royal London Hospitals. Welcome to the podcast.
Thank you for the invitation today.
I presume that the first step when someone presents with chronic cough is to rule out underlying disease. Which diseases should a GP be immediately thinking of when a patient presents with chronic cough?
Most importantly, it's vital to exclude worrying conditions. So look out for red flag symptoms, particularly to ensure that we're investigating promptly for lung cancer. So symptoms that would be concerning, things like associated chest pain, systemic features such as weight loss, fevers, persistent chest infections, or hemoptysis. If any of those concerns arise when you first speak to the patient, then those patients should be referred immediately to secondary care on a 2-week wait pathway. However, if you're happy that none of those red flag symptoms are present, then the common things that you need to consider ruling out are things like COPD and asthma.
Okay, before we discuss those, aside from the red flags you just mentioned, what else might make you suspect lung cancer?
If somebody's got risk factors as well that would make you suspect lung cancer, in addition to those red flag symptoms I mentioned. So if they are a smoker or they've had some asbestos exposure as well, the first thing you need to consider is there a risk of lung cancer, and that should prompt an urgent referral.
And you were just sort of mentioning smoking there, because that's one way to indicate their risk of lung cancer. I mean, I presume a good history taking is going to be really important because you sort of want to know about the smoking history, but what other things do you want to be asking about?
It's also important to think about whether there's anything such as an atopic history or allergic history of hay fever, asthma, eczema, exposure to any chemicals or medications or drugs. Do they have any pets? Speed of onset, nature of the cough, and then specifically looking in your history for things that are treatable traits, such as was there a viral precipitant? Is there any associated symptoms of rhinitis, wheeze, heartburn? Do they have any symptoms of sleep apnea? And there you can use, do they have any symptoms of snoring? You can use common questionnaires such as the Stop Bang and Epworth Sleepiness Score to try and help you with that.
Okay, and what else?
The things that we would want to ask about as well is the nature of the cough. So is it a productive cough? What were the precipitants? Because that might give you a list of the other differentials. The list of things that would cause a cough can include any chronic lung disease. So things like chronic bronchitis might be more likely if somebody's got a productive cough. Then other things that you might want to ask about are medications that might precipitate cough as well. Do they have any other symptoms like reflux disease, any upper airway symptoms?
Okay, so you're talking there about whether the cough might be dry or productive. Is that going to determine what investigations you perform, or is there some investigations that, regardless of what the cause is likely to be, we'll need to have?
So the history is key in determining extensive investigations, but anyone that has a chronic cough, there's some baseline investigations that are recommended, that being a chest x-ray, spirometry, including reversibility where you have it available, and FeNO, which is a fractionated exhaled nitric oxide test if you have that available as well, and a full blood count. And really there you're looking for other pathologies that might cause the cough. So again, if you had an abnormal chest x-ray that was suspicious of cancer, then that would prompt further investigations. But those initial investigations are the starting point and should be conducted in all patients with chronic cough.
Okay, earlier you mentioned treatable traits. Last year, the British Thoracic Society published a clinical statement on chronic cough, and it also talked about treatable traits. And I'm sure our listeners will know this, but what are treatable traits, and what are the ones that are most common in people with chronic cough?
Treatable traits are conditions that might cause a cough. This is a move away from previous management of cough. It provides a more personalised approach for the individual, and it also recognises that potentially there could be more than one cause for a chronic cough. The common treatable traits include smoking, which we've already mentioned. Medication is a common one, ACE inhibitors being a good example of that. And so anyone with a chronic cough should be considering changing to an alternative medication, such as an angiotensin receptor antagonist. Other environmental exposures, vaping, occupational exposures like chemicals could be a treatable trait. Airways disease such as asthma, so eosinophils in the airways. So that's why doing a full blood count is important, because that might suggest that this individual may have asthma, for example. Upper airways disease like chronic rhinosinusitis, obstructive sleep apnea is very common in the community and could be a treatable trait that causes chronic cough. Gastroesophageal reflux disease, obesity, anxiety, and low mood. And then another under-recognized factor is cough hypersensitivity.
So we'll talk about anxiety in a minute, but can we just expand on what cough hypersensitivity is? I mean, you're saying it's under-recognised, but what exactly is it and how is it managed?
It's essentially been recognised that cough hypersensitivity is probably related to a dysregulation of the neuronal pathways that control cough. It results in a cough related to any environmental irritant that could be a relatively minor irritant, for example, cleaning products, talking, laughing, perfume exposure that wouldn't necessarily have caused a cough under normal circumstances. So it's really related to increased neural activity and a decreased cough control. There isn't an objective test to measure cough hypersensitivity, however.
Okay, so going back to anxiety, if you do suspect anxiety as a cause of cough, is that a difficult conversation to have, to basically say you're coughing because you're anxious?
It can be a difficult conversation to have. However, it's also recognised that anxiety and low mood can be a sequelae or a cause of symptoms. So, part of taking the history and doing a comprehensive examination and building that rapport with patients can allow you to also explore whether there are symptoms of low mood that have come from having either the condition or that could be contributing. And that's where using treatable traits as a means to personalize that can recognize that there can be more than one factor causing a cough. And then as part of that, you can use screening tools, both to test the severity of the cough or how that's impacting the individual. So using cough questionnaires, and then alongside that, anxiety and depression scores.
So you're talking there about how a cough can have a very negative effect on someone's life, regardless of whether anxiety is the cause or it's causing anxiety. But could you just expand on how having a chronic cough could affect someone's daily life?
So the cough itself, because it's very public, it affects how you interact with people. You may be trying to interact in meeting, conversations at work, and conversations are interrupted by cough. Particularly after the COVID pandemic, cough is associated potentially with infection, so people feel worried and anxious about what other people are thinking and can often be embarrassed. It can lead them to avoiding being in public arenas. There's also associated conditions such as stress incontinence that can be embarrassing for the individual. And then anxiety about whether there's an underlying condition that's causing the cough.
Okay, so because you were sort of saying, with treatable traits, you'll look for the treatable traits, you'll treat those, and they might have more than one treatable trait. But is there anything a GP could do to support somebody who's got a chronic cough and it's, like you're saying, having this negative effect on their life?
So recognising the impact of the patients would be the first step, and providing support about those individual effects that may be occurring, providing support about whether there's an underlying treatable trait and providing an intervention if possible, and where the individual has a persistent cough despite addressing those treatable traits, referring into secondary care would be helpful. And then more specific things such as if the individual does have, for example, stress incontinence related to the chronic cough, then referring into urology services also, and providing reassurance as well.
You made reference there to referring a patient if their cough was persistent despite treating the treatable trait. When should you consider referral in these cases? And what about if you haven't identified a cause? Should you refer then?
So first of all, to start with the chronic cough where you've identified a treatable trait, there's recommendations about trying to treat that trait. So, for example, treating gastroesophageal reflux disease if the individual has symptoms of reflux or indigestion, and trying that treatment for a 4-week period. But if things haven't improved, then refer to secondary care. Similarly, if they have some features to suggest asthma, like an elevated eosinophil count or a raised FeNO, then trying an inhaled steroid for 4 weeks and occasionally trying a 2-week course of oral prednisolone, 30 milligrams, could be tried by the GP. But if there's no response to treatment, then yes, refer to secondary care. Similarly, if there's a refractory cough with no identifiable cause, that's also a reason to refer to secondary care so that they can confirm that there isn't any other condition causing the cough, and or provide alternative treatment, or they can provide treatment which will often involve an MDT team, because the treatment for chronic refractory cough may include other support from, for example, physiotherapists and speech and language therapists, and that can be accessed through secondary care.
Okay, just going back to the statement from the British Thoracic Society, that talks about setting up chronic cough clinics. Do you think such clinics should be set up?
Chronic cough is very common. It can affect up to 10% of individuals. So it partly depends on what structures of services are available in your local area, but there are advantages to having a chronic cough clinic. It enables us to have an area of expertise. It's often difficult to access the right multidisciplinary support for these individuals. It requires, as I mentioned earlier, allied health professionals of speech and language therapy and physiotherapy, and it's still a very subspecialized area, managing chronic cough and using speech and language therapy and physiotherapy. Therefore, having chronic cough clinics allows you to develop that expertise and have the right specialist support available. Quite importantly, it enables you to access research studies and things. You've got the cohort of patients and the relevant expertise to enable that to occur.
So chronic cough is common, but it seems to be more common in women who are in late middle age. Do you know why that might be?
There are probably 2 factors that explain that. Women have been shown to have a more sensitive cough reflex. So if you do a study using something that would be a particular irritant, for example, capsaicin, which is found in chili peppers, women are more likely to have more frequent related to their cough reflex. Equally, women are more likely to seek medical attention for cough, and that may be because they're more likely to have other consequences of the cough, such as stress incontinence. So in summary, it's because of a more sensitive cough reflex and more likely to seek medical attention. And to follow on from that, the reasons why they might have a more sensitive cough reflex are not fully ascertained. However, there have been studies looking at menopause symptom scoring and cough for example, there does seem to be an association there, so there's probably a hormonal component to it.
Hi, I'm Chloe Harman and I'm the editor of MIMS, which provides prescribing information and tools that complement the brilliant educational modules on MIMS learning. You might already know that MIMS provides a database of concise summaries of prescribing information for more than 3,000 medicines. We also offer a range of other resources to support your prescribing, such as our drug comparison tables covering topics like HRT products and switching antidepressants, our product trackers, including our highly popular drug shortages tracker, and visual guides to diabetes and respiratory devices, which are especially useful for healthcare professionals running clinics for these conditions. Of course, we also bring you all the important news and updates affecting your prescribing practice, which you can receive straight to your inbox in our email bulletins. As a healthcare professional, you're entitled to limited free access to MIMS online simply by registering. And of course, if you or your organisation subscribe, you receive full, unlimited access to the whole range of MIMS resources. To find out more about MIMS, visit mims.co.uk.
Thanks so much for speaking with me today, Prina. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further learning. Thanks again for listening. I've been Dawn Liz Powell interviewing Dr. Prina Ruparelia. This episode was produced by Till Owen.